Good morning, everyone. Thank you all for attending the Innovation Summit and allowing me the opportunity to speak with you today. I am Sharron Finney. I'm the Senior Director of Cybersecurity Operations of Children's Hospital of Philadelphia. It is the leading hospital in pediatric health in the country and is well known around the world in over 133 countries. I have been in this field for longer than I would like to admit, but at least 25 plus years. Implementing technologies. I wrote my first program on a punch card system. Any of you younger than the people sitting in this front row who have to Google that to know what it is. But I started out in programming, and it eventually led me to two CISO jobs with two of the top healthcare systems in the country, Advent Health and Johns Hopkins, which were wonderful experiences. I am now a recovering CISO, and have gone back to my true passion, which is security operations. And I love building things, and this is a time like we have never seen before to build things that help secure not only healthcare system ecosystems, but also patients, and build in resilience that allows us to continue patient care in situations that organizations have never faced before today. So I have some notes here because, as you can tell, I'm not from DC with this accent. So I'm from the South, which means I will talk your ear off. So if you see me looking down, it is so that I can stay on track and make sure we get through this with time for questions at the end. So I want to frame this discussion first by saying this is going to be about, we're very centric to cybersecurity operations in this new world that we live in. I live it every single day. I get at 6:30 in the morning, every morning, I get a Gartner report that says, here are all the cyber things that happened in the last 24 hours. I have gotten that list for probably 6-7 years now. Every day it gets longer. Every day. I remember a time when I got maybe a CISA notification or an alert, maybe once, twice a month. Sometimes I get 3-4 a day now. That's the world we live in. So I want to talk really specifically about what it means to defend a modern healthcare organization and ecosystem as AI accelerates, cloud adoption expands, and traditional data center boundaries are no more. They don't exist anymore. Historically, cybersecurity has focused on protecting internal infrastructures around an area we reasonably knew. You know, we could walk into it, we could see it, we could put our feet in the ground in a data center, we could look at all the servers. We may not know what's on all of them, but we could see them and we could touch them. But today, healthcare has fundamentally changed over the past probably 10 years. All of our workflows, clinical, business, security workflows, any kind of workflow that you're working with today, travels across cloud-hosted platforms, SaaS ecosystems, AI-enabled decision support, connected medical devices, which is growing. We all know that our IoT environments are expanding, and APIs, which was a thing that didn't exist, used to in a physical data center sense. We would just send data out and we would receive data in. So it was, north-south traffic. We kept everything like in our perimeter, and this is my dance space, this is your dance space, okay? And we don't live that way anymore. We're in a rave, okay? That's what it's like out there. And so and we have this enormous amount of machine-to-machine communications occurring every day that we don't even realize happen because they're autonomous. They just happen in the background of things. So the key message that I really want to leave you guys with today is cyber resilience is no longer simply about preventing attacks. It is about creating and preserving continuity of care. It is about being able to recover our systems quickly, patient safety, institutional trust, as several of the speakers have talked about building trust today, which I think is an extremely important topic to continue to build upon, because it all does depend on trust. Oh, okay, so here's my disclaimer. I have to put it up here. These are not the opinion, these are my views, my opinions, and based on my experience. The content presented here does not necessarily represent or reflect specific Children's Hospital of Philadelphia material, but is a culmination of all my experience from my consulting days all the way to being employed by Children's Hospital of Philadelphia. And so, let's talk about the perimeter, which we don't have anymore. We do not have a perimeter. I think this is one of the biggest transformations that has occurred in any industry, not healthcare. This is not specific to healthcare. We built all of our programs and everything around this on-premise infrastructure. We don't live where we lived 30 seconds ago. That's how fast this changes today. We don't live where we lived 30 seconds ago. Today, these clinical systems are increasingly living and hosted in the cloud. Our AI services are all over the board, everywhere. Clinicians, our staff work remotely. I myself work 1 day a week on-prem at the hospital, but we have clinical staff that telework. We've got clinicians that are based in China, South Africa, the Pakistan, in geopolitical times such as these. From a cybersecurity perspective, having a distributed workforce like that is very challenging, because how do you let good people in and keep bad people out? I don't know, when you open those doors. But what's important here is identity is the new perimeter in this world. Absolutely. It is no longer our firewalls. So because of that, we're now dealing with not only north-south traffic, but we're dealing with a ton of east-west traffic in our networks today that travel between systems, between APIs connecting to the outside world, APIs connecting our internal systems. And we all know that the recent breach history has been focused on API key compromise. Several of the most recent events have been API key compromises. So cybersecurity operations has to make a shift from an infrastructure-centric design to a identity and a behavioral design. Now that doesn't sound like a big shift, but it is a big shift in the data analytics that's required to do it. And as a result of that, we also need to adopt AI strategies and AI tools in order to help us keep pace with threat actors that are continuing to adopt AI. As a matter of fact, I got a notification on that Gartner list this morning that Google identified a threat actor who has used AI to develop a infiltration and an exploit to a zero-day vulnerability. and they can demonstrate the functionality of that today. So, the shift is occurring now more rapidly and rapidly and rapidly as we look towards this. So I want to look back at about 3 events, significant events that occurred that have impacted healthcare. So we have Change Healthcare. This changed the way that we looked at cybersecurity, and particularly cybersecurity operations. It wasn't simply a breach. What it exposed was a systemic dependency on outside ecosystems within the healthcare operations and workflows. We all knew these existed before Change Healthcare. I mean, we knew that we were communicating with Change Healthcare. We knew that we were connected with them. We just didn't realize the impact of what would happen if they had a major compromise. And it sort of opened our eyes to things like pharmacy operations, reimbursement workflows, scheduling, things that really detrimentally could affect care delivery within a hospital environment. So the lessons we learned there were fairly profound, because we can no longer think about just protecting systems and blocking malware or detecting events or intrusions into our environment. We've got to think about now operational continuity, resilience, recovery, third-party containment as well. Cybersecurity incidents in healthcare now are patient care disruptors, period. And that changes how we have to prioritize investments in architectures. The Stryker breach. This was another warning about ecosystem risk, but it was different in the fact that it was identity-based. And it focused on attacking their identity infrastructure to penetrate them. And so their cloud connected environments, workstations, it was malware activity, it was everything they could throw at them, including the kitchen sink from a threat actor perspective, to shut them down. And although it really didn't impact patient care directly, because it didn't affect the medical device side of the Stryker business and that. But what it did do was it shut down ordering systems, it affected supply chains, and it really disrupted for a longer period of time. And we still don't have an attestation from Stryker that they are completely recovered. They have not issued that formally. I think Unit 42 is doing their forensics on that. And they've come out with a statement that says, we've got it contained, we're working on it. And then how long does it take to get that formal attestation that they've recovered? And when do you, as a healthcare system, release connectivity back to Stryker? When do you do that? What gives you the comfort level that you can do that without sustaining further impact to your own internal operations? So this moving forward into this sort of cloud-first architecture, federated identity systems, operational resilience must assume that third-party compromise scenarios are inevitable. Every compromise we've noted in the last probably 4 to 5 months has been some sort of supply chain attack against these systems, because these threat actors know that they can disrupt. So let's talk about mythos. There's so much activity around AI in general, and I think mythos really brought it to a head when when you're looking at code-based development. It is, I think it represents that AI adoption is moving faster than we can govern it. I mean, that's a fact. But I don't think that's really new to healthcare, because we've been adopting applications that we haven't governed for years, okay? We have thousands of them in any healthcare ecosystem. You have thousands of applications. Whether you know you have thousands or not, you do, okay? And so I think that what's important about AI governance to security operations is we have to have a seat at that table, because AI governance is now security governance. We get to figure out how we monitor and have visibility into AI interactions, data flows, API usage, anomalous AI assisted behavior. How do you identify good AI versus a bad AI in your environment? It isn't always just about what you've approved or what you've disallowed or what you've blocked or haven't blocked. Sometimes it's about that thing that infiltrates your environment and operates low and slow underneath the covers, which is basically what threat actors want to do today. They want to operate low and slow, and they want to stay in your environment as long as possible. So, non-human identity. If you had told me 25 years ago that I'd be standing in a room full of people talking about non-human identities on computers, I would have said you're crazy. That's never going to happen. You're never going to have a computer that doesn't have a human attached to it. And here we are. So in these environments, the challenges are the APIs, the service accounts, the OAuth tokens, the cloud workflows, the AI agents, the automation platforms, and the medical device integrations that we have within a healthcare system. The amount of traffic on a network, internal and external, to a healthcare system is astronomical. And the amount of data that flows over those, because at the end of the day, we treat patients. Everything we do is about treating a patient at a specific point in time. Everything we do probably passes some degree or has access to PHI at some point in time. We just don't know when that point in time is. And therefore, we can't map the behavior. So we can't identify the anomaly of that API connection or that OAuth token that looks compromised but may not be. We just don't know. And security operations people, we can only act on what we know. If we act on what we assume, then we break things. And nobody wants security operations breaking stuff in their environment. But the breaking of things can have very detrimental effects to clinical care. If I isolate a device in a surgical operating room while a surgeon has a patient open on the table, and I isolate that device while he's using it because it's got malware on it or it got flagged as having malware on it, then that's a manual operation for me today. I got to pick up the phone. I got to call the surgical coordinator. I got to find out the surgeon that's in that room. I got to find out whether or not he's using that device. Can I isolate it? Can I not? How long will it be till I isolate it? Is the malware going to impact what he's doing surgically? Can it alter the data? I've got to ask all those questions. Now, AI can help me get to some of that, but not all of it. That's why I don't think you'll ever see in my lifetime as a security operations person that we don't have some kind of human in the loop in these systems. But what we've got today, the challenges that we face are attackers know that identities are the key. And as a result of that, They're targeting token, service accounts, API keys, all of those kinds of things. Trusted workload, relationships. We have credential sprawl. Now, we all talked about data sprawl about 10 years ago. Now we have credential sprawl. And our non-human identities, if they have not already, are outpacing our human identities in our ecosystems, which creates a unique challenge. So, as we've seen recently, API keys are the new attack surface. Why? Because they're the things that create EHR integrations. They are the things that allow AI interface engines. They are the things that allow telehealth to occur, cloud application connectivity, interoperability, and medical device communication. So this is why API security has to evolve into a core operational capability for security operations teams and technical teams as a whole. We've got to be able to discover them. We've got to be able to monitor them, the runtime. We've got to be able to do behavioral analytics on these API keys. And this leads us to why RBAC, which is our standard, role-based authentication model, is no longer sufficient. It was built for a different time and place. We have to, it assumes static roles, it assumes stable environments, and it assumes predictable workflows. That is the exact opposite of what we have today. It's the exact opposite. So today we have to be dynamic in the way we approach this. We have to assess device posture. We have to assess its user behavior. I mean, it's a risk-based modeling on how risky is this access and where is it coming from and is it anomalous or not. It's no longer about, well, is the same doctor accessing a system at the same time from two different places, okay? We've gone way, way past that to, is it workload identity? Is it, does it violate an API trust relationship, user behavior, clinical context? What are they accessing, where from? And, a physician, using an approved AI workflow on-prem in a hospital environment using a hospital computer is way different than when they're a remote and managed device. They're exporting data. They're going through an unfamiliar API gateway. So static role and cannot take us to the next level. So we've got to move to this ABAC model, which directly relates to the class guidance that was output. We've got to go attribute-based, and we've got to enable a dynamic, contextual security decision about whether or not we allow somebody access to a system or not. This is where AI can help, and AI hurts a little bit. It can be either way. So, but AI or ABAC asks the appropriate questions. What are they using? Is the device trusted? Are they coming from a known place? What workflow? Is PHI involved? What are they trying to access? Where are they accessing it from? It asks all of those questions. And then it helps us support what we all want to get to, which is that zero trust architecture. It helps support us in cloud environments that are dynamic and API ecosystems, and also AI governance. So we have to move to a multi-layered defense strategy. And I think that this is sort of obvious, and it's very simple to stand up here and say on a stage, not so easy to implement, particularly when you're trying to remodel an existing ecosystem While I equate it to, we're trying to build a house and lay a foundation for a house on top of ground that is experiencing an earthquake. It's hard to get that level and stable, where it will support the weight that you place upon it. And so with that, I will leave you with some executive actions that I think need to infuse our security sort of mantra that the way we approach security every day is we need to treat identity like it's the new perimeter. Treat it like that. Treat it like you would a firewall. We've all configured a firewall rule. We all know what that looks like. We all know the complexities of that. And this needs to be treated no differently. Secure the APIs like they are critical healthcare infrastructure, because they are. Govern AI before it scales. I'm not sure that ship hasn't sailed for a lot of us, but it's important to stay focused on it and to have security have a seat at that table for AI governance. And then align all of your cybersecurity to your patient safety and resilience. Work with your emergency response teams. Work with your business continuity teams at your hospitals to align those programs and run, mini tabletops, run exercises with them so that you can see how this is going to impact you. And then my final thought, which is the future of modern healthcare SOC will not be measured solely by how well it detects, responds, and contains. We will eventually be measured by how effectively it preserves trust, it establishes and supports continuity of care, and a safe innovation in an AI-driven ecosystem.